Good afternoon, everybody, and welcome to today's Adult Care and Wellbeing Overview and Scrutiny panel. And I apologise, it's cold. I hope you've all got a hot drink to keep you going. So, welcome, and have we got any apologies, Alison?
Yes, we have apologies from councillors Andy Fry, Joe Monk, Alan Amos and James Stanley.
Thank you. Item 2, any declarations of interest from the councillors? No, not today. Good. Item 3, public participation. And today we have Anne Eyre, who's come to ask a couple of questions. Thank you.
Thank you. Good afternoon, everyone, and thank you for the opportunity to come and speak to you today about a agenda item about sensory impairment support. My name is Anne Eyre. I'm the Chief Executive Officer of Sight Concern Worcestershire. We're the only charity dedicated to supporting people who are sensory impaired living in Worcestershire. We have a long history of supporting vision impaired people and are now delighted to offer support to people who are deaf, deafened, hard of hearing or experiencing dual sensory loss too. We are proud to deliver information and advice to sensory impaired people on behalf of Worcestershire County Council under the duties conferred on it by the Care Act. The impact of sensory impairment on a person's life is significant and broad. All of the evidence concludes that people with impaired vision or hearing, or both, are much more likely to be socially and financially marginalised, experience poorer health outcomes, particularly in relation to mental health and cognitive decline, be at much higher risk of falls, accidents and injuries. And that's just a few examples. A quality of life study by the London School of Economics concluded that the quality of life for a person with severe sight loss is less than that of people with a variety of other conditions, including advanced breast cancer, depression and long-term arthritis. It is predicted that 20% of the UK's population will have hearing loss or deafness by 2031, and 27% will be vision impaired by 2035. Prevalence and need are growing. Resources are shrinking, and it is incumbent upon us all to maximise the resources we have to find better, more efficient ways of working and meeting the needs which are undoubtedly there. The charitable sector is working very hard to find ways to do this. For example, the Eye Care Support Pathway was published last year by the RNIB in collaboration with a wide variety of partners, including vision impaired people, local charities like Sight Concern Worcestershire, the Association of Directors of Adult Social Services, Department of Health and Social Care and NHS England. I would like to ask specifically today, what is the local authority's response to the Eye Care Support Pathway and how will it work with partners to ensure that the pathway is embedded in Worcestershire to ensure that vision impaired people have access to the information they need at the right time? Sight Concern Worcestershire is ready, willing and able to work with the council to provide responsive, person-centred and holistic support to all sensory impaired people. There are very successful examples across the country of models of joint delivery, improving lives, achieving much better outcomes and reducing demand on wider services. I acknowledge the support which is already available and which you'll have read about in the report, but urge the authority to make use of the skills, knowledge, resources and relationships which exist in the third sector to improve this. By working together, we can deliver meaningful support to enable sensory impaired people to overcome the barriers and challenges which are created by living in a society which is just not designed to include them. The opportunity is absolutely there, and we would all be failing people with sensory impairment if we do not take it. Thank you very much. Thank you, Chair.
Thank you, Anne. We appreciate you taking the time to come to our meeting and asking the questions. We will get a written answer to you afterwards. You're very welcome to stay and listen to the rest of the meeting. Thank you. Okay, item 4, minutes of the meeting on the 20th of January to be approved. Has anyone got any questions or are you all okay? Yeah? Agreed? Thank you. Item 5, update on the implementation of the Integrated Care System Autism Strategy. We have had a look through the presentation, so thank you for that. And we do have some questions lined up for you. So if you'd like to briefly go through the report. Thank you.
Okay, so hello, my name's Laura Westwood. I'm one of the lead commissioners for adult social care, and I also co-chair the Autism Partnership Board in Worcestershire. And I've also got...
Hi, I'm Hazel Shaw. I'm the co-chair of the Autism Partnership Board as well.
So I was just going to go through a bit of an overview of what the paper says. The autism strategy for Herefordshire and Worcestershire was co-produced by the Autism Partnership Boards in the two counties. We had quite a lot of co-production and engagement on that strategy, so we're confident that the strategy says what autistic people wanted it to say. We've got a strategy that largely mirrors the national autism strategy, which is the first autism strategy that was all age nationally. So 6 of the priorities which we've got in the table in the report, the first 6 are all priorities that are in the national strategy, and then we've got an additional priority for Herefordshire and Worcestershire around keeping safe. The autism strategy went through a sign-off process last year and then was launched in April 2024. So we're just coming to the end of the first year of the strategy. Each of the priorities has its own priority lead across the different organisations, who leads on the co-production of those priorities, but also on delivery of the action plans and reporting back. What that does mean is Hazel and I won't necessarily be able to answer all of your questions today. Some of it will be us going out and finding out the answer and coming back to you. There is a governance structure around the strategy. So we have a group which is chaired by the ICB that oversees the strategy called the Autism Strategy Oversight Group. That pulls together all of the priority leads who lead on the priorities to look at progress and feeds back quarterly into the Integrated Care System, Learning Disability and Autism Programme Board. We also update annually and always have done in Worcestershire to the Health and Wellbeing Board, or that may now be the Being Well Strategic Group. And we're due to report there in May at the end of the first year as well. So I was going to do a whistle-stop tour of what we've achieved. Do you want me to do that, picking out some key points from the presentation, or do people want to go straight to questions? Yeah. In the first priority, improving understanding and acceptance, there has been some progress in that there is now a neurodivergence zone that's been co-produced and is on the local offer website for Worcestershire. We know that there is some comments on that local offer webpage and the neurodivergence zone, but the door is open to still co-produce the content that's on there. There's also some actions planned around having some audit tools for retailers and public spaces around making sure that buildings have sensory adaptations to enable autistic people to access them. And most of what we've done in the first year is exploring funding options for those, setting up provider forums of local providers who work in the autism space, to talk to those providers. And we've also recently established an autism reference group to get more voice of autistic people. Priority 2 is quite closely linked with the SEND strategy action plan for Worcestershire. So what's happened so far has been there's quite a lot of analysis undertaken of the themes from the support review. A lot of what was planned around the strategy was more engagement, more voice of the young people and carers, which there is progress happening on that. Hazel and I were at an interactive event last week, which was looking at progress on the SEND strategy action plan. So we've linked those two pieces of work. When we come on to priority 4, there has been quite a lot of work happening in terms of diagnosis and support around autism, and in priority 2 there's also been work to look at what does the education system need to do to work alongside that. There's been a review of any schools that haven't accessed free training that's on offer, and an analysis of why that's occurring. There's been a recruitment, and there will be a new children and young people co-production officer being recruited and will be in post in April. The NEAT strategy has been finalised. The Worcestershire Autism Mentor Programme is now embedded into schools for autistic children. And a new Year 9 toolkit has been co-produced with parent carers to look at annual reviews of young people, and I know there's work going on in terms of a Year 11 one as well. Priority 3 is around supporting more autistic people into employment. So there's been a review of the current programmes, employment programmes with providers to look at what outcomes are being achieved for autistic people. So previously that hadn't been a measure, and there's been some work to benchmark the effectiveness of those programmes for autistic people. There was an inclusive leaders forum with 28 employers came along, and that was they raised the profile of employment practices with autistic people. And there was a Life Beyond School event to young people with special educational needs that was attended by 364 young people, and very well received by those young people and families. In terms of priority 4 around health and care inequalities for autistic people, the integrated, so the ICB are responsible for delivery of the Oliver McGowan mandatory training programme, and I know when we talked to the Health and Wellbeing Board about autism, I know the board then had their own Oliver McGowan training. That training is being rolled out, and funding has been secured to extend that training offer into sort of September of this year, and we're pleased with the take-up. It's not the take-up exactly that we would want, but that is a national picture, and there's issues around Oliver McGowan training in terms of people's ability to take the time to conduct that training, and also around whether that's the appropriate training for each person within organisations. So work continues on that. There has been a sensory and friendly environment piece of work led by the ICB, where they employed and trained autistic people to go out and visit GP practices across Herefordshire and Worcestershire. And it's really positive that 66% of GP practices will have had that audit completed by the end of this financial year. There's also some other settings that have been looked at as part of that project. There's been a big piece of work, like I mentioned before, looking at diagnosis and support for autistic young people. A proposal has been co-produced for an autism and ADHD diagnostic service to work across Herefordshire and Worcestershire. That isn't fully funded at the moment, but it's positive that the work has been done. We've got a proposal that is there, ready for when the NHS funding comes through, and we can work out then which bits of that can be delivered and when. In the meantime, there is an interim right to choose process in place for young people with autism, and also some of the people waiting for diagnosis have moved from the children's waiting list onto the adults waiting list to try and free up capacity. On to priority 5, building the right support in the community. The work that's been done this year is commencement of a needs assessment around support for people. So quite a lot of the feedback that we had in the autism strategy engagement and co-production was that people may get an autism diagnosis or know that they're autistic, but then they don't know where to go for help or support. So we've conducted that needs assessment, getting information about what is there out there for people, making sure we've got all of that information in one place. And then there is a forum set up, like I said before, with the providers to talk to them about can we plan that to support then in a more planned way so that we know exactly what the gaps are in terms of any business cases we need to make going forward. There's been quite a lot of work alongside public health, looking at autism priorities and suicide prevention strategies. Autistic people are at higher risk of dying through suicide. So we have done work alongside district collaboratives and the Suicide Prevention and Loneliness and Isolation Partnership, that's always a long one to say, to look at how we join that together. And there is a specific event next week around autism and loneliness and isolation, suicide prevention. In terms of social care, we now have an adult neurodivergent team in place to look at the social work assessments and support plans of individuals with autism and other neurodivergent needs. That team has done an extensive training programme this year and is now sort of fully equipped to meet the needs of that cohort. There's been some work done with district councils and housing colleagues in terms of looking at housing allocation policies and training needs, again, in relation to autism. When you look at priority 6 in terms of improving support in criminal and youth justice systems, this is led by West Mercia Police. And I think it's a really good blueprint of what a single organisation can do to make this strategy happen. So some of the things they've done is they have embedded autism training into all of their staff. So their custody sergeants and their police inspectors now have autism training as standard. They've established their own internal autism network. They're also spreading that work across into the victim support services that they commission, and they're doing their own needs assessment in terms of whether they need to do any more in terms of that offer, really. So they didn't collect that as a specific number in the past, and they've set up mechanisms to do so. They're also looking at their protocols for how they work with autistic people who may be having a mental health crisis during their kind of interaction with West Mercia Police. And they're also looking at how they gain feedback and what they do with that feedback. So quite a lot of work has gone on around Priority 6, but like I say, it's also sort of learning for us as each organisation about what we could do ourselves. Priority 7 is a little bit further behind in terms of its development, but now has a project group established around it and someone to lead that priority going forward. And we've also sort of summarised what we think the key risks are as a group of programme leads. Do you want to add any?
I think you've covered it perfectly.
Okay. Thank you.
Thank you, Laura. Apologies, I forgot to welcome Emma Marshall, who's the chair of the Children and Families ONS, who's joined us today. Sorry. We do have some questions lined up. Who would like to start? Do you want to start then, Emma? Because I know you've got a couple.
Yeah, sorry, I have got a few. So thank you very much, and good afternoon, everybody. So looking at the report, it's something people might know that I'm quite keen on talking about is that co-production and how we can ensure it becomes embedded in the culture at county. And it's kind of a similar question I ask at children's, so I'm going to ask it here as well for the adult side of it. And how do we feel that is going forward now? Do you feel it's starting to become embedded? Does it start to be a natural first point of call that we'll actually go for co-production, or is it still something we've got to think quite strongly about? I think, who wants to take that one?
So, as well as being the co-chair of the Autism Partnership Board, I'm also the co-chair of the Worcestershire Parent Carer Forum as well. So we support and look after the needs of families with disabled children up until the age of 25. So it's sort of, I can wear both hats for this answer possibly. Co-production's got a long way to go in Worcestershire. I think it's fair to say. I keep using this line, and hopefully I think it's still appropriate. There is the ambition to co-produce in Worcestershire. I sense that from people, but we've got a whole culture to change. So certainly, you know, we need to move forward and we need to work harder at it. But there is the enthusiasm there to make that happen. We just need to now take the next steps to move it on. We've got a co-production training that's coming up, which will bring together all the relevant professionals from across health and social care and you know, SEND services, etc. So we need to move hearts and minds in the right direction, but there's a long way to go. But I think people are listening now and wanting to move to that model. So does that answer your question?
It definitely does from your point of view. I'd like to hear maybe from an offerer or maybe even the cabinet member about how they feel we as the organisation can move and help meet that, you know, expectation of our co-production allies that are working with us, but also how we can push that culture change within the organisation from our point of view.
So I suppose just to answer from the autism point of view to start with, we've always had quite a sort of, you know, robust autism partnership board in Worcestershire, which is all age. I think the membership of that board has changed over time. So I think initially, when I first got involved a number of years ago, that was quite an adult-focused autism partnership board, because there was no diagnosis service for adults when that board started, and that has changed. I think over time now that has morphed, and it's a more all-age representative partnership board. So that does include people with lived experience on that board, but we have recognised that there are people who don't want to come to a formal meeting and don't want to co-produce with us in that way, which is why we've now set up the Autism Reference Group. So we've got a newly formed reference group, which is a lot more informal. People have chosen how they want to partake in that. And that was really positive meeting, again, chaired by a paid person with lived experience. So I think that's been a really positive move.
So this one's a bit more of a let's try and look at it from the other point of view. Are there areas where co-production would actually impede progress and be a disadvantage? And how are we then open and honest with the other organisations we're working with to say, on this occasion, it is not going to be appropriate for us to co-produce this report, this item we're doing?
I think there are times when I think we've got to have a total understanding of what co-production is, because co-production says that you start with a blank piece of paper, and there are times in our work delivering statutory services where we can't start with a blank piece of paper because we've got statutory duties that we have to fulfil. So I think we are opening a dialogue with being a bit more honest about that now, because I think the word co-production perhaps has kind of been used interchangeably with engagement up until quite recently, whereas I think now we are being a bit more honest and saying, okay, these are the things that we're going to engage on because they're the things we have to do. These are the things that we can co-produce with. So I think that dialogue is changing as we all understand co-production a bit better. Don't know if you want.
Yeah, I was only going to say that because there was previously a lot less co-production across Worcestershire County Council, we can't, everything can't be co-produced from the off now. We'd make no progress. So we have to pick our battles and start with the things that are most important. And as the culture changes, we'll be able to move through more projects, etc. So.
Thank you. Richard, did you want to come in?
Thank you, Chair. Thank you for the question, Emma. Yeah, and thank you, Anne, for the water. That was good. I think this report brings it a long way from where we were, so I really celebrate and congratulate the team and where they've taken it so far. But I think co-production is evolving. I think you're quite right. It's where we're progressing to. We're working very effectively with many partners, whether that's Speakeasy now, whether it's Site Concern, and there's more we can do with Site Concern because they're broadening their remit as well from just site to hearing and other areas as well. So I think those partnerships become pretty key. Where I'm coming from perhaps is more on the training, because I think we have to help people understand more about the area that we're looking at here, and that I was concerned a bit where you said the Oliver McGowan training may not be the suitable training, and then that there's poor take-up of that training as well. And that's where I think we need to address, because that helps bring people on board with wider knowledge and wider circulation of the activity that we're talking about.
Thank you. Matt?
Thank you, Chair, and thank you for the report. I've got just one question around, probably covers priority 1 and 3, just kind of get some examples of how employers are working with autistic people, how they're kind of both helping them in employment, but also helping them that kind of idea of kind of culture and understanding, how that is improving. It'd be nice to have a few examples, if you have any, of how some successes over the past year. Thank you.
Yeah, I probably should ask Judy Gibbs, who leads on that priority, to say what successes she would want to say. I know some of what she's done in terms of the Inclusive Leaders programme has been sort of sharing practices. And a lot of that is around awareness of people's sensory issues. So some of the work that I've explained that happens in GP practices around, what can you do to make this workspace more accessible, that the same kind of principles apply at work for some of those things, which is around noise cancelling and lighting, and understanding people's need to have a space to go to, relax sometimes and take a moment. So yeah, things like that. Autism is an exciting thing to work on, because I feel like there are little things that each organisation can do that make quite a massive difference. But yeah, we can get you a list of what those examples have been. I also, as one of my other hats, manage the Learning Disability and Autism Supported Employment Service in Worcestershire, which sounds grand, but it's a team of one. So we have some really nice examples online of people accessing work as well, and videos that we can share with you.
Thanks, Laura. I think if we bring this report back next year, that would be good to have that included in the report, and some case studies from Judy. Is that okay? Do you want to come back, Matt?
Yeah, I was just thinking maybe a concrete example of a GP, because my son, who's autistic, had his first proper flu he'd never had before, so he thought he was dying. So he clearly, so he'll contact the GP then. So he did it himself online, but obviously because he's autistic, filled in the online form, doesn't like speaking on the phone. So ticked the box saying, how do you want to be contacted? Message. Didn't tick the phone. Obviously, what happens? Half an hour later, they ring him up and do you want an appointment? He's there, very monosyllabic. Me in the background going, yeah, say yes. No, yeah, you want an appointment, because they're offering him one later that day, which is great. Because I've got like maths. I can't, it's just like, no, do it. So I suppose it's just that awareness. I assume on the records they knew he was autistic, but probably didn't that's not on the form. So it's little things, as you say, it's those little examples like that. If I wasn't there, he probably wouldn't know what to do, and he'd probably, say, no, I can't do that because I've can't go to college and I've got to keep my 100% record. I must have my 100% record. So those kind of examples, that kind of GP's surgery, probably a little message to them will probably, oh, we didn't realise. So, yeah, more examples like that would be good. But thank you.
Thanks, Matt. Lynn?
Thank you very much. I wanted to follow up on the employment bit. I mean, first of all, the strategy was absolutely enormous, and I think I was on the Health and Wellbeing Board when it was presented there, and there's an enormous amount of content to it, and clearly, a lot has been achieved or begun in the last year, so well done for that. One of my questions about the employment bit was going to be, is the LEP involved? And then you said Judy Gibb is the lead, so I won't ask that question. There is something about kind of how is it being monitored? Is there going to be KPIs? You're actually going to be able to measure increase in employment or improvements in employment. And there's kind of no mention, and actually it's kind of going to the kind of baseline of going into employment. So, in terms of the job centre and how the DWP treat people, because that is a very problematic environment and a fairly unforgiving environment, even for kind of robust citizens, let alone vulnerable ones.
Yeah, in terms of monitoring, so each priority has an action plan and has set out how are we going to monitor that we've achieved it. Some of the way you will monitor it is we did a massive piece of engagement, a questionnaire that went out to, and we had a massive response to from autistic people, providers, professionals, but also quite a lot of members of the public responded to that questionnaire. So there will be a need to repeat that at points to check how we've done, is how some of that will be checked. Some of the work around autism is difficult because it wasn't necessarily a category for a lot of these organisations to start with. So you see the work with the police, they're just starting to look at, okay, if we measure autism, what have we achieved? So some of that might be more difficult in this strategy, and it might actually be the next iteration of the strategy where that improves, because what the NHS are doing as well is introducing a digital flag for autism, which will make a huge difference for all of us in terms of monitoring, because at the moment that isn't on their systems and it's being introduced. So that's probably a bit of a fudgy answer, but basically the short answer is we're trying, I think.
Thank you. I think
Sorry, what
because
about the job centre and the DWP?
What's the question? In their monitoring, or how they...
Any engagement with them with regard to, the autism strategy, their training on autism and helping people with autism and having an understanding of that?
Yeah, so they have a number of employability programmes that GD's team work with them on. So all of that assessment of the effectiveness of those programmes and the outcomes that get achieved will include the DWP in that work.
I can give anecdotally, I took my eldest daughter into the job centre recently, and as we went in, she started to have a meltdown because she was overwhelmed. She's autistic as well. And actually, I found them pretty good. I mean, I'm hesitant to say it out loud for fear of jinxing things, but they were actually pretty understanding, offered us a separate room, offered to meet in a different location, pretty supportive. I also am autistic, and I went in recently for another reason, and again found them pretty supportive. So yeah, I don't know whether I'm white and middle class and, you know, and can hold my own, so I suspect I get better service than a lot of people, but my personal experiences have been pretty good.
Thank you. And I think because this is the first time that we've seen this strategy before us, we're learning what we'd like to see from the next time. And I'm sure Judy works with the DWP a lot, so that's why them connections are there, and to improve them, we can pass that on to Judy. Thank you. Paul?
Thank you, Chairman. What sort of difficulties do autistic people have with transport services, please? I don't understand what the issue is.
Okay.
Yeah, I suppose if you look at, for young people, it's access to transport. So, for example, some young people, you know, under the age of 25 aren't necessarily able to drive, and it's availability of transport. The on-demand bus has helped, certainly in South Worcestershire. I've seen, certainly, I know a number of young people that are now using that on-demand bus to be able to get about. The environment of a bus and public transport can be tricky, very tricky. So overstimulating, too noisy, too many questions, too much life all in one small space. So that can be particularly difficult. Yeah, I mean, I think it would be the same as the national picture, to be honest, as for Worcestershire. It's the environmental challenges of using public transport that are a big challenge. Does that answer your question?
Continue, Chairman?
Yes, sure.
Similarly, you've got comments around here, or notes around target schools. And some you've offered training to that haven't come back to you for the training. What's the issue for that schools need to know with? Because you might laugh, but you know, I've not experienced any of this. I do know a lad with Asperger's syndrome, but for the most part, I don't understand the difficulties. And it's similarly and if you've offered schools training, I would have thought that schools would have been an area where there would have been enough autistic people that teachers would have noticed, and if you're offering training which would help, I would have thought that they would have been wanting to take it up.
Okay, I'll let Hazel talk about what some of those issues might be in school, because she's going to be the best person to do that. Again, I'm not necessarily the right person to answer the question around what's happening in education, but I think there has been a lot of support into schools, and there's a complex needs team that is really well regarded in Worcestershire. That is special. They specialise in autism, and they do offer training into schools and tailored programmes. And I know that the mentor programme has a really positive impact, which has been putting mentors in for autistic children in schools, and we've had really positive results from that. So there's some negatives, there's some positives. So I think you need to take it like that. But in terms of children's experience of school, that can be a very difficult place for an autistic young person to be. And I don't know if you want to give a few examples of why.
A few, yeah.
We might have to...
It's encouraging me not
Yeah.
to say too much there. So some of the schools think they're good at autism, and the reality is that they're not. So they don't take the training because they think they've got it sorted, but they really haven't. So I think the people that come on the training tend to be the ones that are really motivated and want to do the best, and the ones that don't come on the training are the ones that it isn't a priority for them, or they already think they're good at it. So I think that's the reality. There's challenges around academy schools. Obviously, as I understand it, the local authority have, or the county council have, less control over what academy schools do and don't do. So I think there'd be a correlation between the academies and the schools that don't go on the training. That would be, I haven't got any evidence to back that up, but that would be my instinct. I agree that the CCN team, the Complex Communication Needs team in Worcester, we're very lucky to have them. There's some real expertise around autism, and they're very neuroaffirming, which is important, and I hear good things about the mentor programme. We're about to roll out the PINS project in Worcestershire, which is this is the phase 2 of the project, where basically they're going to be looking at the inclusivity of 30 primary schools in Worcestershire to make them more accessible for autistic young people, and the teachers on the SENCOs and the staff get training to support that, and it includes an element of co-production where the Worcestershire Parent Carer Forum will be working with the schools and the parents to embed that culture of co-production in those 30 primary schools. Again, it will be led by the primary schools putting their hand up if they want to be involved. So I suspect we'll be talking to the same people if we're not careful. But yeah, more work to do, I think is the answer.
Thank you. And if this comes back next year, Chairman, perhaps we could do with some numbers, please, on numbers of schools that are interested and that aren't. Thanks.
Okay, that can be included in the next report. Thank you. Emma?
Thank you, Chair. I just wanted to talk about how we are raising awareness of some of the great projects that are going on and support groups. I know at the Needleworks in Redditch there is a support group there, but of course not everybody is on Facebook, so we can't rely on just one form of media, and not everybody now listens to the radio anymore. So how are we using a multimodal type of messaging system to really reach out and ensure that those who need to know about this, that targeted approach but wide, to make sure people who do need the support are aware of it?
I'm excited at my response to this because part of what we talked about at our first autism reference group is where do you look for information? Because we're doing this mapping exercise. We're going to put that information onto our directory on the County Council website, but we asked this group of autistic people, where do you look for information? And nobody really said they look on the County Council website. Everybody said we are interested in what other autistic people say who are on social media. So we know that we need more of a social media presence from the autism strategy, and we're lucky that we've got people like Hazel, who's got quite a lot of communications experience. We've got other autistic people that we had a YouTuber, didn't we, as part of the group. So yeah, I think we've got some resources we can tap into to make us better at that. I suppose what I would say in this setting, don't know if I should or I shouldn't, Rebecca can kick me, is that we don't have any money to do anything with this strategy. So this strategy is something that works on the goodwill of people to sign up and deliver it. We've got a statutory duty to deliver it, so it's not just goodwill, but we don't have any printed resources or web design or any of that sort of stuff to behind this strategy. So we do what we can as officers, basically.
Can I add to that?
Yeah.
And I think I'd encourage people to think about the overlap between the disenfranchised SEND parents and the autistic community. There's a big correlation between those audiences, and actually there is some good work going on, and actually if we don't tell anybody, they won't know about it. So actually the communication around the good work that's happening needs to be supported, I would suggest, and encouraged, and made possibly some money.
Maybe the Cabinet member could take that back to the Cabinet and speak to the relevant people. Thank you. Emma, you wanted to come back?
You took the words out of my mouth. I was going to say, can we please ask for the Cabinet member to have a look into this and see how we can further ensure that we are catching that net wide enough to actually be able to support the people who really need it.
Thank you. And Matt?
I was just going to add there, I suppose it wouldn't just be our Cabinet member, it's a whole population strategy. So I suppose it is the Health and Wellbeing Board's responsibility as well.
Richard could do that work for us, though, can't you, Richard? Sow the seed.
I can, and I'm just noticing on the website that Wychhaven isn't represented, but the other districts are, so I'm just writing to Wychhaven as well.
Thank you. And was it Matt next, and then Lynn? Oh, sorry.
You seem to have forgotten.
How can I forget you? Let's go to Adrian first then. Thank you.
Thank you very much, and thank you for the report. I have a number of different questions, and I'll start with priority 5, where you do mention building the right support in the community. Within my particular area, I have arts and crafts, and I'm really happy to support it and to fund it. And I think that we as councillors are possibly a starting point to make sure that we can help the people that are in our areas, because you can't necessarily know everything that goes on, and councillors hopefully should do within their area. So I would like to see a little bit more two-way communication, because the people at Arts and Craft, for example, all they wanted was £20. So if somebody doesn't know where to get funding, it's extremely difficult. And the county councillors do have divisional funds and are happy to help with those sort of things. So if something can come out to us councillors, I'm sure you'll get a response coming through. On another point, in terms of what you mentioned with regards academy schools, we really must work together to ensure that autistic children are not marginalised or even expelled from some of those schools, because the schools are inclusive for everyone. And I have been very concerned in the past where even I haven't been able to get really a decent response from the schools back. But we as a county council recognise that we have that responsibility. So if even we can go back to the cabinet member to ensure that we get a good rapport with the CEOs of the academies, because I think if we can start at the top, we have a good way of disseminating the fact that this needs to be done down to the other academies, because otherwise they can often just close the door, and it is difficult. But I have had complaints myself of this type of thing, and we as a council, I think, need to address that and take the bull by the horns. The other point on priority 3 is a question in terms of after post-COVID, working from home, has that actually opened up job opportunities for those people with autism, where previously there were possibly other things in the way that stopped them getting jobs? Because I do know of people who within my area cannot get out, cannot go out in public transport, but therefore working from home has been something fantastic that's enabled them to actually get jobs. And I just wondered whether that had been promoted more across the board to other occupations where there's working from home available.
I don't think that's something that we focused in on year 1 of the strategy, is my understanding from GD. I suppose in answer to the question, I think it will for some and it won't for some people, because people are going to have different reasons why they might find work difficult. I know from, even from our Autism Partnership Board's point of view, we've got some people who prefer to be online, some people who much prefer to be in person. So, yeah, I don't know if you want to say anything from your point of view.
I think the experiences of autistic people varied greatly during COVID. One example would be that a lot of people found the working from home and the reduction in environments which they struggled with hugely beneficial. So, they thrived. And then there are other people that struggle with the lack of routine that came, or the change in routine that came from that. I think the bigger struggle has been when people have been returned to work, and there's been a push for people to go back into the office, and that's particularly difficult for autistic people. I mean, I myself, I used to work in an office, and now I work from home. I have no intention of ever going to work in an office ever again. It's overstimulating and too busy, and it's just not good for me. So I think that the bigger challenge is the push by many organisations to return to the office for at least part of the week, and people have worked out that it's not good for them. And then there's the whole challenge around persuading organisations to make reasonable adjustments. So you'd be well within your rights as an autistic person to say, I don't want to come into the office one day a week, I'd like to stay at home. It's much better for me. But actually a lot of organisations really do struggle with trying to understand the concept of reasonable adjustments. You can spend a lot of time advocating for those adjustments before you'll even get them. So I don't know if that answers your question.
It does, but then we are letting people down if we are not able to get the message across to the employer of the importance of ensuring all their workforce are supported. So I totally understand exactly what you're saying about the employer, but therefore it is up to us as a local authority to try and get the message across in a more prominent way to them, because they have to be all inclusive. It's even my other half has difficulties getting on crowded trains. I often have to jump on the bike and go and pick her up from Birmingham. So it's a matter of working to a suitable solution with the employers.
Thank you. Matt?
Thank you, Chair. It's a very quick, specific question. In priority 2, it mentions parental blame session planned. I was interested. Obviously, I know it's not going to be a session where you try and blame all parents, but just a bit more information about that. Thanks.
Yeah, so there's some work gone on regionally around parental blame that some of the parent carers involved in the Autism Partnership Board have been part of. Do you want to say a bit?
Yeah, so the research has proved that there's a correlation between being an autism family, whether that's the child or the parent, and blame, being blamed, or even worse, fabricated induced illness. It lives and breathes in Worcestershire. There's no way of getting around it. Several of the parents that were involved in the research are Worcestershire parents, and they're coming the next Autism Partnership Board. We're going to bring that research through to discuss, and we've got some local parents that are coming to speak about their experiences of being blamed, and often they're not upheld, and yeah, it lives and breathes in Worcestershire is my point.
It's linked to, so there's a cross-cutting theme in the strategy around masking. So that there is some autistic people, usually women but not exclusively, try to hide their autism. And that will happen with again, primarily girls in school, which can lead to a sort of conversation of, well, this isn't happening. But obviously puts a lot of pressure and stress then on the young person that they are having to pretend to be somebody else between 9 and 3 and then go home and are, having a meltdown at home that the parents then have to pick up. So, yeah, it's sort of an important thing, and it is, particularly coming up around young people in education.
And can I just add that the new attendance regulations that have come into force are exacerbating this problem as well. So if you're struggling, I think it's something like, I'm going to get it wrong, but something like 90% of children that have emotional-based school avoidance turn out to be autistic. But obviously then if you can't access a diagnosis to prove that you're autistic, because there's a 3-year waiting list in Worcestershire, that's one problem. But then also the new attendance regulations are really quite draconian on parents, and then you're who are unable to prove your child's autistic, they can't attend school, and the regulations are now talking about, are prosecuting parents. So, it's the perfect storm as a parent to an autistic child.
Thank you. Oh, go on then.
Just because it just, triggered so many memories of doing those parenting courses that I went to because of my son, even though he was the second that went through the school. And I'm not sure I learnt something from the parenting courses, but I suppose this, hopefully things have improved since that was maybe, 12, 14 years ago. But I suppose, do you think it has? And who is this these courses going to go to? This is it aimed at teachers at school to get the heads at school to really get an understanding of, don't just think it's bad parenting. Have you looked into, obviously sometimes it may be, but interested in that area.
Yeah, I suppose the start of this is, so there's been some work done regionally which was led by, again, someone who is a parent herself of autistic child, I think, rather than children, child, and has experienced this herself. She led a piece of work. There's now some promotional material that's been produced regionally around that. So our Autism Partnership Board, the next session, we've invited some key people to come and listen to that, work out what does this mean to us for Worcestershire, what do we need to do to take it forward. So we're kind of at the beginning of that, really.
And just to say, the parenting course for to access an ADHD diagnosis only got dropped last year, so it's been happening for the entire time that you've been.
Thank you, Lynn, and then we'll have the final question from Adrian.
Thank you. I've got more than one question, if that's all right, Chair, to pick up on. Kind of moving on to the health inequalities. My first question, and I've never heard of a reasonable adjustment digital flag project manager before. Actually, what exactly is that about, and what will they be doing?
So there's going to be a new requirement that there is a digital flag on NHS systems to pick up that people are autistic, which at the moment there isn't. So there's a whole sort of raft of work around that, because once that flag is ticked, that means that each of those organisations needs to understand what are we doing about that, then what's our reasonable adjustments for that cohort. So there's sort of a couple of pieces of work that go together around reasonable adjustments, digital flag, and it will be a really positive outcome for autistic people, because it will mean that people are recorded on a system and weren't previously. And there's a whole raft of things that we're hoping are coming in through, the new NHS plans that, so we know at the moment people with a learning disability have an annual health check. There's talk of that's going to be there for autistic people as well, but you need the flag first, because that won't happen otherwise. So hopefully it will open doors for people as well.
Thank you. That's really interesting, and potentially kind of plays into my next question. So, as a homelessness forum, that I attend as a district councillor, and I think it's kind of reasonably well evidenced that there is a disproportionate level of autism or neurodiversity amongst the homelessness population. And certainly it was given at a recent multi-agency meeting the example of a person who required to have a scan undertaken as part of their health condition. The only way to physically access the scan was via the A&E department at Worcester Royal Hospital, which is a very intense environment at the best of times, and the individual just was unable to wait in the waiting area to access the scan that they needed. And then, of course, they're put down as a default on the scanning appointment, and you get kind of a downward spiral of, interaction and support from health. So, that was an example of an obstacle for a homeless person, but actually, it's an obstacle. That is what health inequality for autism looks like, isn't it?
We have examples of young autistic people that need to access CAMS, which is the Children's Mental Health Services, but they're unable to access them because they can't go in the building or they can't leave their home, but yet they won't come to them. So across health, there's lots of inequalities that they generate through their own inflexibility and failure to make reasonable adjustments. It's accessing health as an autistic person is particularly tricky. And it's only as good as the person that you meet on the day, and there's so many people. You know, I went for surgery recently and I wore my lanyard, and they didn't know this. The anaesthetist didn't know what my lanyard meant. Well, it meant I was autistic, and that's why I wore it, to give them, you know, advanced warning. But he didn't know what the lanyard meant. The list goes on. Very tricky.
Thank you. Okay, finished? Yeah. Adrian, you're the last one.
Thank you very much. I am very concerned with what you've mentioned or what's been highlighted about possibility that 90% of children's absences are emotional-based school avoidances, and yet, because of their lack of diagnosis, means that there's a possible prosecution for their parents. Waiting 3 years is not acceptable for a diagnosis in this case. And what we need to do, we or the education system at some point, has to make a change so that the first thought is there a problem with this child with emotional-based school avoidances based on autism? And if that is the case, we need to be able to trigger a push up the system in some way so that they can get that diagnosis sooner. Is that something that we can do?
Again, I don't think that's a question I can answer. That cuts across a couple of the projects. Like we've said in the presentation, there is a new diagnosis pathway been designed, which has been co-produced, which if it's put into place, will sort of ease that diagnosis issue, and that there has been work between education settings and health to look at what that pathway needs to look like. The risk is that pathway isn't funded at the moment and may not be, so there'll still be an issue. There is a lot of work to try and reduce the waiting times, but I don't think anybody anywhere would think that the waiting times are acceptable for families or for young people at the moment.
Could I ask our cabinet member whether we as an authority have that ability to make those changes that I mentioned?
I don't think we solely do. It's a partnership. It's with the NHS and other providers. I think there's unparalleled demand at the moment in terms of assessment, and that's part of the issue. I think as more people become aware, that increases the number that require assessment, I think. So I think we need to work with our NHS partners, and it's I'm adult social care. We need to work with children's and other areas as well.
I think if we can bring this up, therefore, at children's, and to make sure that parents, as a result of this, are not prosecuted, I think it's a severe problem that I wasn't aware of, and I think now we've been made aware of it, we need to make sure that we can look at a solution so that the first port of call for prosecution is to say, right, we can't prosecute until we've got this diagnosis, because it just runs in the face of our judiciary, missing something extremely important as a diagnosis of autism that ends up with parents being prosecuted. I do not think that is acceptable, and we now it has been highlighted. I do believe we need to take this further. Thank you.
Thanks, Adrian. We have Susie James from Health Watch here. Is there anything you'd like to add? Or Margaret, sorry. And seen you sneak in.
Hello, thank you, Chair. No, I mean, just to say that Health Watch is obviously actively interested and engaged with this issue. We do attend the Autism Partnership Board and we'll be looking at and reviewing the strategy and the issues that have been raised through our membership of that board. So thank you.
Thank you. Richard, is there anything you'd like to add?
I'm just picking up with Adrian's last point, really. So I think possibly if you feel inclined and Emma feels inclined as the chairs of the relevant scrutiny panels to put a letter to the Executive Board, I think we could look at it that way.
Thank you. Yeah, that's a good start.
I'm not sure school avoidance is an adult social care issue, with due respect. I mean, I'm just, yeah, I absolutely hear the problem and the difficulty.
You're quite right. I'm going on the basis that it's raised at adult social care. So, yeah, but I mean to cabinet, not to had my witch-shaven head on.
Thank you.
I was just going to make a suggestion, because obviously we've got this parental blame session happening, which has got appropriate officers from Children's coming, because I'm conscious we haven't got a sort of officer from Children's Services to answer the question for you. So perhaps, you know, if you want, we could give you an update what happens and what actions come out of that parental blame session, and then maybe build on that. And children's officers will be involved then in the conversation.
That would be great, thank you.
Sorry, Emma.
Can I ask that even though I'm not a part of this panel, that I get included in with that update, please? Thank you.
Yeah. Hazel, Laura, thank you both for attending and for the excellent work that you're doing. So thank you. We will move on to item 6, which is sensory impairment information and support available. And I'm handing over to Kerry. Thank you.
Thanks, everyone. If I can introduce you to Morgan Price, he's our head of service for a variety of things, one of them including sensory impairment. So Morgan's going to give you a summary of the report, and certainly we're both on hand to answer questions.
Thanks, Kerry. Yes, thank you. My name is Morgan Price, head of Home First, which includes responsibility for the sensory impairment team. And just firstly, thank you for inviting us to share information about the work that team within the council do. Just worth noting that the report and the paper actually focuses on the operational delivery of council services, but it's important that we recognise that there's a broader offer, including a commissioned advice and information service. And this paper gives an overview of the work that the team carry out, as well as information and support that's available to adults with a sensory impairment. So the sensory impairment service is part of the Adults Communities Directorate, providing support to adults aged 18 years and over with a sensory impairment. And that can be people with a vision impairment, a hearing impairment, or a combination of the two. And one of the fundamental principles that the service uses to inform its work is recognising that a sensory impairment is unique to an individual. And the significance of that was emphasised earlier by Anne in this meeting. In addition, impairments and therefore support needs can change over time, and so the service adapts its support as needed. And the types of support that the service provide include training, support and advice on mobility, daily living skills and communication skills. And they'll also provide equipment to support independence. And alongside that, they will also work with families and family members and carers who might be supporting that person. The service provides specialist advice and support to other teams within the organisation too, and that helps to make sure that all needs are considered across all service areas, particularly when we're considering a holistic needs assessment. And the service also provides awareness sessions and has provided quite a significant number of these for teams across the council. The service uses the Care Act to determine eligibility, and it operates within that legislation and other legislative frameworks, for example, the Mental Capacity Act and the Equality Act, amongst others. And we receive referrals through the standard social care process, which is usually via the adult front door. And we also have an open referral process, which includes self-referral, referrals received from other professionals who were working with the person and with their consent, and also direct contact from the other teams in adult social care who are working with a person. And the papers outline the makeup of the team, along with some of the key skills that they have, which enables them to work effectively with the people who need support. We monitor average caseloads and also waiting lists to make sure that we've got sufficient capacity to meet demand. But we should note that while we were writing this report, it became clear that there wasn't a single data set that the team can use to actually monitor its own performance. So we've already committed to undertake further work with our business intelligence team colleagues to identify data requirements and also to build some reporting which will then enable us to monitor that more effectively. And then in addition to the direct assessment and support that the team provide, the training sessions that have been provided for wider staff in adult social care has been really helpful in raising awareness of the impact of sensory impairment. And the team are currently contributing to the development of e-learning, which we're hoping will be rolled out across the Herefordshire and Worcestershire integrated care system. And we've also contributed to a deaf and hard of hearing awareness e-learning module, and that's due to roll out in May during Deaf Awareness Week. The paper also outlines how the team works in partnership with other organisations. In particular, we have a close working relationship with Sight Concern, and just last week we received a lovely note of thanks from one of their sensory impairment advisors after a couple of members of the team attended a hard of hearing cafe which was set up by Sight Concern to provide expert advice for people attending. And I just wanted to draw attention to the case studies in the agenda pack. These give just a few small examples of the impact of the team and of the service on residents. And also wanted to highlight the references in the paper to what is referred to as LawDig, which the team participate in. And LawDig is the Local Authority Workers Deaf-Blind Interest Group, and it's a sort of peer support network across the country. And it draws on expertise from all across local authorities in order to provide peer support, and it helps to develop and support best practice. And the paper gives several examples of organisations who we work collaboratively with. And we'll also always recognise the value that joint working provides to individuals with a sensory impairment. And I particularly wanted to highlight the work the team recently undertook with a Ukrainian study tour, which was aimed at sharing information about the role of the sensory impairment team and how they work with people. And that was intended to help the Ukrainian visitors consider how they might set up or improve services in Ukraine. And those examples just show how the sensory impairment team, really small team, is not only having a local impact on Worcestershire residents, but also a national impact through their participation in LawDig, and now an international impact through the recent collaboration, which was facilitated by New College Worcester. So yeah, that's a summary of the detail in the paper, and just once again, thank you for having the opportunity to share some of the really positive work the team do. And we're happy to answer any questions you have. Thank you.
Thank you, Morgan. That was great. And it's really good to see case studies as part of the report. It sort of makes it a bit more real. So thank you for that. And shall we go over to questions? Adrian?
Thank you very much, and I am pleased to see this report. However, what support do we actually give, or advice do we give to employers when a sensory impaired person wishes employment in, for example, in the building industry? Because I am aware of people who have hearing difficulties not being allowed on site because of the risk assessments that are necessary in these particular jobs.
So I don't have any specific examples from the building industry in particular. I guess we work with employers, we work with the individual, and depending on their circumstances and their employment, we'll sort of dictate the relationship we have with the employer. I have to say, from feedback from the team, many employers are really open to conversations about what adjustments could be made to support a person. And we certainly help with things like access to work. We work in collaboration with Access to Work to make sure people have equipment and items that help them to do their job. employers are always very positive about the outcomes from those. Alongside that, obviously, employers have to make sure that they comply with any relevant legislation that applies to their industry. And I guess, I'm certainly not an expert in the building industry, but I imagine that there are a number of health and safety risks that they would need to take into consideration for anyone working on a dangerous building site. I'm certainly happy to go back to the team and ask if we've had some particular specific experience, but generally the feedback from employers has been positive, and I'll be happy to provide further case studies in future for employment support.
Thank you. Yeah, that will be good. Matt?
Thank you, Chair. Thanks for the report. Just going back to a point you mentioned about caseloads and waiting lists. Within the report, it mentions how many FTEs you have, and it talks of about 20 cases per worker. So I'm not sure if that's a good number. Is that too many per case worker? So a bit more information about what you'd like it to be. Thank you.
Well, I guess it's variable, mostly because the numbers on the caseload aren't just with the sensory impairment team often. So it's usually around I would say a 70-30 split. So 30% of the people they're working with are probably allocated to another team as well. So it's more about an element of work that they're doing that supports a broader needs assessment. So really what we're probably talking around is about 15 people that a worker might be responsible for. And the level of complexity is a part of that mix. Some people, it's a relatively straightforward piece of support. So it might be about making contact with somebody who's newly certified with a vision impairment, going out and just having a conversation with them, understanding what support they might need, if any, making relevant referrals, signposting, providing some advice, and then that's the end of it for now. But for others, it might be much more complex, 6 weeks support, direct support with, for example, cane training or learning a new public transport route. There can be a number of different pieces of work. So the 20 number is a little bit of a misnomer. It's much more about the capacity of individual workers and their skills. We do talk regularly about any particular pressure points. We sometimes might find that we get a flurry of a type of referral and we don't have enough skills in the team to manage all of them in a timely way. So how do we prioritise? How do we work through that list, but also communicate with people effectively so their expectations are, they understand what we can do and when we can do it, and there's no disappointment. As things stand, the capacity is about right. We get very few complaints about delays. We get very few elements of negative feedback. We get quite a lot of compliments, which suggests that we're generally doing a good job. So I don't know if that provides any assurance.
Okay, Lynn, thank you.
Thank you for the report. I must admit, it's a service I wasn't really very aware of, which suggests there's a bit of a kind of a publicity gap, and as someone who's from a health background, been involved with health and well-being, and actually quite passionate in terms of accessibility, for services and premises and so on, for people with disabilities. I'm not sure how I've missed you really. A couple of specific things to kind of pick up on. You say, talking about waiting for people who are waiting for cataract surgery might be experiencing difficulties. I don't know whether you're aware, the wait time for cataracts is, so short, it is negligible. I am of an age where, a lot of my friends, my husband's friends, they can't get you in quick enough. There is a very rapid referral system from the likes of sort of Specsavers and Boots, and it is through the NHS, but there is kind of commercial delivery. There's almost kind of cataract factories, for want of a better description, I know up near Six Ways in Worcester. So I guess if that was previously a significant part of your workload, I think, you know, in the current environment, that has shifted. And, you know, if maybe you need to kind of refocus in terms of the support and what's needed. That also kind of prompts me to ask the question under referral process. So the likes, say, of, you know, the high street people, those are franchise services with professionals, but they deal both with impaired sight and impaired hearing. As to, you know, are they aware of, are they able to refer individuals into the team? And then a final question, which kind of partly was prompted by Adrian's, as to the role, anything in terms of prevention. So one of the reasons there's a risk on a building site if you can't hear properly, but it is also a location where, using noisy equipment, people can have their hearing very significantly damaged. And I think yesterday was some kind of Deaf Awareness Day, and I saw it promoted via the nighttime industries. So, you know, loud music in nightclubs and so on is a huge risk. So is there any kind of work or any connection with public health around prevention?
Thank you. The example of cataracts in the paper, I think, was to highlight that sometimes the team will work with people who are in between statuses. So you may have someone who's experiencing a temporary situation. So cataracts is maybe now a poorer example of a lengthy, what used to be quite a lengthy wait. But you will get people who are perhaps, they've had an acute incident and they need some support while they're waiting for maybe a longer term diagnosis of what the issue is, and therefore a treatment plan. So the team will work with a person while they're in between statuses, if that makes sense. And I think we use cataracts as the example because it used to be a case where there was a longer waiting list for that, and it's just part and parcel of the literature that we use in terms of describing that situation. Your second question around the referral process, and can high street referrers, providers refer? They can, yes, and we are very clear that we just require the consent of the individual for the referral. And we do often provide a number of pieces of advice to high street providers around what to do if they are concerned about a person needing support. So there's a sort of a two-way process there. It's not perfect by any means, but I think it does mean that our high street providers, such as, you know, Boot Specsavers, for example, who provide some of those commissioned services, they know that they can contact us and they know that they can send a referral through to us for us to follow up, particularly if somebody is certified. And then the third question around prevention, I think this is probably an area where we don't have a huge amount of work in the team. The awareness part of it is certainly one part that contributes to prevention. You know, an awareness of sensory impairment allows us to maybe identify somebody at an earlier stage who either might be at risk of impairment in the future or is currently experiencing impairment for which there might be a solution or some corrective action that could support them, or certainly something that might you know, prevent or reduce the impact of that, or certainly delay the progression of a condition. So I think the awareness sessions are certainly one part of the puzzle, but it's a much bigger puzzle than we've got the pieces for at the moment. And I think we would probably need to maybe take that away and consider how we could build that further into the prevention work that's in place in terms of the prevention strategy.
Thank you. Can I just follow up and ask whether you are aware or the team are aware of, excuse my back because otherwise you can't hear me and see me, whether you're aware of Access Able, which is the it's an online app and a mapping system, and will map any kind of public spaces and identify, the level of disability friendly, whether there's a disabled toilet, whether there's hearing loop, and things like that.
Yes, it's one of our best friends. And I certainly know that the team are really, really passionate about not just using what exists currently, but they're also often quite keen at exploring the sort of cutting edge of assistive technology. So things like navigational tools, they're really keen to understand what's out there. Recently had a conversation with one of the team around a long wait for a guide dog for a person that they support, and talking about 3 years potentially waiting for a guide dog, and they were exploring a prototype piece of equipment for the person. It looks a little bit like a lawnmower, but rather than it just being something that has sensors that can guide you away from an obstacle, it can actually use GPS to map a route between 2 points, as well as that sort of ad hoc sensor-based guidance. Really, really interesting piece of kit. Unfortunately, very, very expensive, as prototypes often are, but we're hoping that the more that we explore options like this and we get into a conversation with some of these providers, potentially there might be opportunities in the future to test new things and potentially be part of the shaping of that market. So really, really, it's a really exciting area, I've got to say. One we're all passionate about.
Thank you. Any further questions? Adrian?
It's not really a question, but it's a thanks. I would like to thank Site Concern myself, because they have responded to one of my residents in a very, very quick way, who has suffered quite a bit, because not only do people have sensory impairment, but sometimes it goes with other issues as well, such as autism, and when it comes together, people can suddenly find themselves in extremely vulnerable positions. And I do appreciate the help that both our Cabinet Member and Site Concern have given, so I'd like to say thank you.
Thanks, Adrian. Margaret, is there anything you'd like to add from Health Watch?
Yes, there is, Chair. We've got a few questions we'd like to just raise. How do you want, shall I do them in little blocks? Would that be the most appropriate way?
How many have you got?
We've got 3 or 4 areas that we'd like to cover. I'm making it sound a lot worse than it is. It's not that scary, really.
Fine.
It's just about giving the officers time to respond, rather than giving them a great big long list of questions in one go.
How would you like to take them, Morgan or Kerry? Or if it's too much, we could get a written answer to you afterwards. But if you'd like to fire away to begin with, and we'll take it that way. Is
And
that
some
all
of this
right?
we might well need written answers to anyway, because it might be that the information isn't readily available. But we were interested, first of all, we're really pleased to see the report here about the team and the work of the team. And we're really pleased as well that the panel has picked up on the report that we did prepare. It's sensory impairment. I was late for this meeting because I've just been on a call with our ICB colleagues around sensory impairment and the importance of accessible information. And it's an issue that I've been working on since I joined Health Watch about 8-9 years ago. And it's an issue where themes recur as well. So we know that there's a lot to do across the system in terms of addressing things, as well as celebrating the good work that goes on. So I just wanted to start by asking, in terms of the waiting information that you've given in the report, you talk about numbers of people waiting, but what would be really helpful would be to have an indication of the time that people are waiting. So what sort of minimum, maximum, average waiting time is there before people get a face-to-face assessment? And also, does that time vary according to the person's impairment? So, for example, if I am deafblind, do I wait longer than somebody who's got a vision impairment because the skill mix in the team? So some sense of that would be really helpful, I think. So we would be grateful if you could provide us, and I'm sure members would be interested in that information as well. Do you want to respond to that, Mum?
Thank you. So as I explained when we were writing the report, we realised that we hadn't got a single data set which fully enabled us to sort of monitor our own performance. And one of the things that we struggled with was that differential between the different types of impairment. It's probably a key ingredient of us being able to understand how to prioritise work within the team. In terms of the how long people wait, the only figure I can give with any certainty is that people with who receive a certificate of vision impairment, once that's shared with the sensory impairment team by the ophthalmologist, the team usually respond within 24 hours to confirm that we've received it and to make arrangements for the next steps. The only exceptions to that is if there's a delay in the ophthalmologist sending the certificate, or if we receive it on a weekend, and it might just take us a day to pick up that email from the ophthalmologist. But that's the only figure out of all of the work that we do that I can give with any certainty. So we do need to develop our ability to pull that information out of our data. We'll have it, we just don't have the means to pull it together at the moment. And I think the other question, the other element of this around, does that vary around the skill mix of the team? I probably need to take that away and chew it up a little bit to be able to provide a response that I've got any confidence with, if that's okay.
Yeah, that's fine. Thank you. I'm really pleased that you read about the certification and registration process, because this is something that came up in our report when we talked to people. They told us that it was, from their perspective, it wasn't always a smooth process. And one of the recommendations that we made, and one of the responses that we got from the system, was that individual organisations were going to sort of review their processes to see that they were sort of efficient and streamlined and worked from a person's perspective. So it would be useful to have an update on that process, that internal process of review, but also to understand how that links over then into the acute trust, because I think we feel as Healthwatch very strongly that this is one area where actually we really would need the system to work together on this. So rather than reviewing things as individual organisation, so what we need is a look at the process from the ophthalmology department forward, from the point of view of the patient, really. So I just wanted to raise that with you as well.
And I can confirm that from an internal perspective, we did look at the process of receipt of the... I understand what Lynn was saying now. It feels really strange answering your question with my back to you. We looked at the process from the point of receiving the certificate from the ophthalmologist, and then how we then dealt with that internally. And we just refreshed our internal processes in terms of our duty system. So our duty worker now has a series of tasks that they work through, one of which they undertake as a priority is to check for any emails for certification, so that we're able to then contact the person as a priority and get them onto our radar in terms of making sure that we can have a conversation about any assessment and support that they might require. So we've managed to, as a result of that, and that's why I'm able to tell you that figure quite, that 24-hour figure quite confidently, because that's an area that we've improved. In terms of the acute trust, I'm not really able to answer on their behalf, but I do accept and acknowledge that there needs to be a joint approach to this. It won't work if we do it in isolation.
Thank you. I think that's something maybe the panel might want to have a think about as well, because I think that is pretty critical from a person's point of view. And that kind of window being opened to information and advice at the point at which people are diagnosed is something that we heard loud and clear from people about a gap in the system currently. And that it sometimes leaves people feeling really isolated, really ill-informed, and sometimes, in a clinical setting, having been given a life-changing diagnosis and sitting there feeling quite devastated with no information about follow-up support, what's available, where they can go. And some of our conversations with people with sensory impairments, both vision and hearing impairments, we've asked them about the team, what's your experience been like? And some people simply haven't heard of the team. And it seems to me that, there is a real opportunity there to raise that profile and that awareness through the certification process. So we would be really pleased to see that being taken forward. I think that whole issue about knowing what's out there is a really important one. So a big question from us, I suppose, is how does the team promote its work, and where does the team promote its work? We know as a Health Watch it's really difficult to get your name out everywhere that you want it to be, but it would be interesting just to have a bit more information about how and where the team does that. And I can't have an item about sensory impairment and not talk about the accessible information standards, because that would be very remiss of me. I think one of the things that is raised with us really consistently by people is the difficulties that they have in being able to understand, have their communication needs met, basically have the requirements of the accessible information standard, which as we know is a mandatory standard, have them met consistently across the piece, so that if somebody has been identified as having a communication need in one setting, that information transfers across into another setting. And I think it would be, I know we're talking about the team today, but we would like to understand whether across adult social care you feel confident that the requirements of the accessible information standard are being put in place and are being met, and that you feel confident that people with some kind of a sensory impairment are getting an equivalent service to somebody without that impairment. So I'd be interested, and we know this is a process and a journey, but I think when I go back to talk to groups I've been talking to for 8 or 9 years, they are beginning to say to me now, when are we going to notice that this journey is getting better from our perspective? And we really want we really want to be able to go back to them and point to some good stuff and say, this is what's changing, this is what's happening. So we are really looking at that from this perspective. And I've just had a very similar conversation with colleagues in health. So your thoughts on that would be very welcome.
Thank you. Quite a lot there. I've jotted it down. I think I remember it all. So the comments around raising the profile of the team and the sort of how and where does the team promote itself, I think it's probably fair to say that up until probably around 6 to 8 months ago, the team, we had a couple of vacancies in what was a small team, so we struggled really just to, wash our face, just keep on top of the priorities that the team had. We were fortunate that we had a decent recruitment campaign, and we managed to recruit a new worker into the team, very experienced worker, into posts that are very hard, they're quite challenging to fill, these posts. We also created a new role in the team, which is a senior reablement worker. And the focus on it really is about supporting people to not only to adapt to a new sensory impairment, but also to understand how we can look at some of the reablement type approaches with people, so making sure that we provide information, equipment, support that enables people to stay independent. As a result of that recruitment, we've got better capacity in the team, and we've already started having conversations about how do we promote the work that team do. I certainly know when I have my supervisions and one-to-ones with Kerry, I've said a couple of times that we need to be able to promote the work that sensory impairment do. They're often a little team that's overlooked, but do a lot of good work. So I really want to start advocating for the team more. One of the ways that I think we're helping to do that is we've got quite a flat structure in the team. So any member of the team can have a direct conversation with me as head of service quite easily, quite simply. I was at their team meeting last week. We're now in a position, I think, where as a team, we're more able to engage more broadly than we have before. I certainly enjoyed being part of the review that you carried out, Margaret, recently, that contributed to the writing of this report, and we as a team welcomed some of the recommendations because they matched the areas of issue that have been talked about a number of times before. So I think we're in a better position, and that allows us now to start to raise the profile of the team in terms of undertaking some of this work and promoting the completion of some of that work. In terms of the accessible information standards, I think I could give a fairly generic answer and say, I think we're doing what we can, but I think we can do more. it's probably more an organisational thing rather than a team thing, and I'm not the right person to respond more fully to the question around confidence in whether the adult social care are meeting the accessible information standards. I'm not sure whether Kerry would want to comment on that. Yeah, I'll hand over to Kerry for a comment.
I think it is. It's a broader council-wide responsibility, isn't it? And actually, that's part of reviewing all our documentation, the website, and the accessibility is something that is underway. So I think we'll come back to you from a council-wide perspective, which would absolutely then include where are we at in adult social care and what more do we need to do.
Thank you.
Can I make one final point? I know I've had a long session, but just one final point, which is around digital exclusion. I mean, it's something we've talked about at this panel, I know, quite a lot, but I just want to mention the fact that for people who can use websites and people who can use screen readers, people who are fine and happy with BSL Relay, those are fantastic opportunities for people to access a world of information and advice. However, we do know that, and in particular people with sensory impairment, there is a whole community of people who cannot access those means. And therefore, we are very keen to see that promotion really does range across a whole range of formats, and that information is consistently provided in a way that is accessible to people and meets their needs rather than meets our processes. Just wanted to make that point. Thank you, Chair.
Thank you. We do appreciate your comments and participation, so thank you. Adrian, you've got one quick question.
It is a very quick one, actually, and it's reminded me of one of the residents of Rubery that actually contacted me. Are we able to make recommendations and write to the government regarding simple proposals? Because we all have biometric passports, but for those who have sensory impairment, they often have to check in at the airport, and this particular resident did not know that their passport had expired, because there isn't a way that they can actually feel or read that the date on the passport. So just something simple added to the biometrics of the passport could make it accessible for those with other needs. Thank you.
In short, I'm not sure, but it's something that I'll happily go and have a look and see whether, I mean, certainly on an individual level, we would provide support to the individual. If we knew that they were planning for travel, we might be able to provide some specific tailored support around travel plans and making sure that relevant documents, visas, etc. might be in place. But in terms of making more broader recommendations, I'm not sure that's something the team would ordinarily do, but I think we could maybe take that away and consider whether that is part of their remit.
It was very difficult for me to deal with, as he was at check-in at the airport and wanted me to do something. So we can't do everything.
Thank you. Richard, is there anything you'd like to add?
Thank you. I've got a few points. So one, thank you to Morgan and the team for the report and all the work that you do. Two, I was a bit sad being a Labrador owner about the issue with guide dogs and guide dogs potentially going out of business with technology, but I know from guide dogs and Labradors that they give a lot more than just supporting routes. They give the friendship and they much more warmth than technology would do, although I do believe we should look at technology as well. Three, partnership, and I'm pleased that you work very well with Site Concern and how we can work effectively together in terms of the offering. And looking at the website, we do signpost to Site Concern and access to work, although I accept the digital exclusion as well. With Health Watch, the accessibility is really important, I think, there. And I think also it would be good if you look at the website and make sure that we do have the right details there as well to support. And then I'm really pleased that next week I'm spending time with the team. So I will learn more and be able to report back.
Thank you, Richard. Good luck. Okay, we'll move on to item 7, performance and 2024-25 in-year budget monitoring. And we have Richard and Katie with us. Who would like to go first? Sorry, Kerry, do you want to start now?
Just to introduce Katie to the panel. So this is Katie's first time at Scrutiny panel. She's new into post. You will have observed we've had multiple changes in this area over the last year or so. You had myself presenting for a while and I think Pip came to the last one. So Katie's going to run through the report, but certainly I will support where needed, and any questions that Katie can't answer, she will certainly go away and find out as they're just in that handover stage.
Don't worry, we'll be gentle with you. But we have had the papers and read them, so just a brief summary. Sorry?
Well, just to ask what Katie's name and title is. So we can't email Katie or communicate just with Katie.
No, that's fine. So it's Katie Stallard, and I'm going to be the new performance manager for adults and community, but I can send on my email address to you all afterwards. That's absolutely fine. Okay, so obviously you've all had the report, so I'll just go through it quite briefly with the key areas that I think I need to raise for you today. So you've got the 5 key performance indicator areas. So I'll start with the first one, which is admissions to permanent care for 18 to 64 age brackets. So the latest data is a rate of 19.4 for December. Breaking this down into routes of admissions, you can see that the 60.3% of admissions are from hospital or discharge to assess pickups. The majority are from community hospital. 11.8% are from short-term residential and 8.8% are from community services. This indicator remains with a RAG rating of red, and this is based on a target rate that we set here of 13.4. We have seen performance improve between Q2 and Q3 this year. However, it does show that there's a deterioration in performance when compared to the same period last year. This indicator will be closely monitored during the next few months, with results shared monthly with the adult social care managers as a means of supporting performance improvement. In addition to the monthly data reporting, the business is routinely scrutinising all placements with the alternatives to admission considered as the preferred option. So moving on to number 2, which is the admissions to permanent care for 65 plus. For December, performance has decreased to a rate of 515, and this is from 534.6 in September due to a drop in admissions, with only 54 coming in for December, which means this is assessed as green, based on a target of 645.9. Performance shows improvement when compared to the same period last year and from March 2024. The data shows that the largest proportion are coming from hospital and discharge to assess pickups, 42.2%, with 17.8% coming from the short-term residential. 20.8% are self-funding pickups and 8.8% are from the community services. Since we've introduced commissioning conversations for older people, physical disabilities in September 24, the LD and mental health were already in situ. Alongside the new framework dynamic purchasing system, we are seeing positive results in accessing care and support in the market for older people and are focusing on working age. We continue to ensure continuing healthcare decisions are examined, but have seen an increase in the numbers coming out of continuing healthcare eligibility in all areas, but particularly working age and people who are receiving fast-track funding. The profile data for this indicator is included within the report. The latest data shows that there is a little difference in the data for total average age of admissions by care type from what was reported in September. One highlight is in the admissions by primary support reasons, which shows a decrease in numbers for the 65 plus age bracket. This is reduced to 737 compared to 765 in September. The biggest decrease was within the physical support, personal care support reason, from 472 to 435. There is little difference in the data for the minimum maximum of average age at admission from what was reported in September. For number 3, the outcomes of short-term services, the latest data for December is 80.3% and remains a RAG-rated amber due to it being below the target of 84%. During winter months, the trend is that performance is usually slightly lower, and the result is similar to last year, but with a higher volume of people performance has shown small improvements, with the latest data for January showing continued improvement. Our latest benchmarking data shows Worcestershire's performance on reablement outcomes is significantly above the national average and also above that for the comparator authorities, and as a result performing well in this area against comparators. There are continued pressures in the urgent care system, and an ongoing focus on reablement outcomes has helped to maintain performance in this metric, but this will be another indicator we monitor monthly within the service to keep on track of performance. People aged the next one, number 4, people aged 65 plus at home following rehabilitation. So the performance has very slightly decreased from September, from 82.4% to 80.9% in December, and shows deterioration when compared to performance last year. It is currently RAG rated as amber, but this is based on a stretching target of 83%. When comparing the latest quarter data available, Q3 against the previous quarter, Q2, we can see that there is a decrease in the count of deceased people, 74 in Q2 and 68 in Q3, which is an increase in people remaining in hospital, 50 in Q2 and 56 in Q3. This is an indicator where performance does tend to drop during the winter months, with the main reasons listed for those not at home were either because they have deceased or remain in hospital, which continue to be the main reasons for unsuccessful cases. We'll continue to monitor monthly to see if this trend continues, and the latest benchmarking data shows Worcestershire is performing above comparators and the national average in this metric. So the final one is the annual care package reviews completed. So performance for December was 81.3%, meaning this indicator remains rated red against a stretching target that we set here of 95%. This nationally is an area of performance in decline, and the latest data shows a decrease in performance locally since September, when it was 87.4%. When compared to the same period last year, it does show deterioration. However, demand in teams remain high, and as a result of workforce pressures during winter months, more contacts and more people receiving services, and towards year end, this continues to remain challenging to maintain performance against this indicator. If there's any questions.
Thank you, Katie. Well done. Any questions from anyone? No? Oh, go on then. Go on, Matt.
There's a couple, the first one and the last one, those kind of both kind of indicating, well, one's a big increase and one a big drop. So are there any specific reasons why we've seen those kind of differences in performance, both negative in the sense that they're going the wrong direction? Did something happen in the past few months?
So the first one around the admissions for 18 to 64. I think there's an increase in demand in this area nationally, working age. So that will lead then to more people in permanent care. What we're also seeing, although we don't report here, is we've increased those numbers of people into other types of accommodation, extra care, supported living. So it isn't just residential and nursing settings, so the overall numbers are increasing. The scrutiny that we put in before a decision is made for somebody, regardless of age, but particularly those kind of conversations for younger people, is really high, and therefore we're confident that people will only go into residential care if that is the only option available. The other thing to consider are the numbers that are feeding through from children's services, so around the kind of support in the transitions, and we're starting all that early work with younger people and preparing for adulthood and looking at what those housing options might look like. But for a number of young people, those decisions are already made due to the complexity of their needs, and therefore they'll be adopted into adult services. And we've certainly seen a higher number of people coming through, and therefore that will be reflected in those figures. The other one, in terms of reviews, so we often talk about this target. It's a Care Act statutory duty to carry out a review. So we set it at 100%. But I think if you looked around the country, and certainly locally, we know many teams are around 50%. We managed to invest at 2 different points and targeted 2 different areas, one of them being learning disabilities and one of them being the area teams, to bring some external support into reviewing, to bring those numbers up. So we will have seen improved performance, but that was never going to be sustainable. So, you know, we also have to recognise the number of people that receive services. So I think a year or so ago we had 6,300. We're now into 7,200 and something. We haven't had that equivalent investment in terms of staffing into the teams. In fact, in some teams what we know is we've got reduced staffing as we've had to make some savings. So managing reviews is always going to be a challenge, and they are usually people that are safe and they've got services. So they won't always be the priority. What's key for us is how effective the process is of reviewing, and whether we can start to bring in some of those means of self-review that may meet better the needs of different cohorts that, you know, we've talked about today, where they may be able to use different types of tech and do that, you know, electronically rather than necessarily always having face-to-face reviews, so that we can carry out as many as possible, ensuring people are safe. It's also about ensuring their outcomes are met, quality of services, but also, you know, is it at the best price the council can pay, and is it the right level of support for those individuals 12 months on. So we will continue to monitor those targets, but I do repeatedly say to our teams, we are still doing really, really well in terms of trying to keep on top of those reviews. And we also monitor those that have gone significantly over 12 months in our monthly performance meetings to make sure that, you know, those that are heading into the 18 months, for example, are targeted. But as quick as you've done that, more people will roll into that category, but it won't be the same people. But, you know, that's part of us prioritising the current resources and the demand coming into the service.
Thanks, Kerry. Okay, Matt? Okay. Margaret, is there anything you'd like to add? No? Richard, anything you'd like to add?
Only echo what Kerry's saying, really. I think it shows the value and what a great team we have, because with all the financial constraints, all the efforts they make to continually try and meet budget and try and improve their service, they still deliver. So we're very fortunate.
Yeah, thank you. We agree too. And well done, Katie, on your first one. And over to you, Richard. Thank you.
Fantastic. Thanks, Chair. So I'll be walking you through the overall corporate position for Q3 and then a bit more detail relating to this panel. So at Q3, we are projecting to forecast an overspend of 14 million on our budget of 433. So that's around 3.5% overspend. We have seen a deterioration from Q2 of around £1.5 million as an organisation. The majority of that is in relation to children's social care, albeit there has been an increase within the adult services overspend. The themes that we're seeing which are driving the overspend, I think we all know, but I'll reiterate it again. We've got children's social care, adult social care, home to school transport. Still prevalent. I'm sure when it comes to outturn, they're still going to be the main driving factors for our overspend. I would say it's not necessarily all doom and gloom for a lot of directorates. We have seen some areas that are managing to underspend, so that's obviously positive news, and that helps offset the overall position. Directors for each directorate are still looking at mitigating that in-year overspend, because we've had a lot of conversations on the finance of the organisation. So yes, just to put that out there, we are looking at mitigating it. The table on page 60 of your reports details by service area what is the forecast now for period 9 being December versus where were we last year. So I'm not going to go through each area of the table. We can just see it there at your ledger. Touching on savings, we have an overall savings programme of 38.4 million. We're forecasting to achieve around 75% of that. So there's £6.3 million worth of savings that are identified that are at risk. Again, in the table we can see by directorate where those savings are. Within adults we have the £1 million which we've reported last period. Touching on reserves, we have a reserve balance of £105 million at the start of the financial year. By the 31st of March in 2027, we're looking at to diminish to £32 million. The majority of those reserves are earmarked. The only unearmarked area is our risk reserve, which starts at £43 million and ends at just over £10 million at the end of 2027. So yeah, not a good picture. Where we are with regards to the capital programme, that was approved last month at full council, so the 3-year programme stands at just shy of £490 million. The in-year programme is £102.8 million. We have spent £71 million out of that programme to date. The majority of the programme is funded by grants. The rest of it will either be a mix of borrowing, receipts or revenue implications. So if we do borrow money, there are revenue implications of borrowing that money. But the majority of our programme is funded by grants, which don't incur that revenue cost. And the overview of the capital programme is on slide 64 for you. So if I move on to adult social care, December, so period 9, we're forecasting overspend of 5.1 million. It has increased from around the 4.67 million from the last quarter end. We've seen overspends within the main service areas that we deliver care for, so older people, learning disabilities, physical disabilities, mental health. All client-led demand service areas, and we are seeing fairly significant overspends in this financial year relating to those areas. I'm going to move on to the information on slide 67. So I touched on the £5.1 million overall overspend. You will see in the slide pack it says £6.1 million overspend. So learning from my presentation at last quarter with one figure saying 5.1 and one saying another, what I'll say is if we split the budget into the two main cost pressure areas that we see, we have staffing with a budget of around £26 million, and then what we're spending in the external care market, which the budget is around £265 million gross. So within our external care market, we're forecasting an overspend of £6.1 million across all of the client groups. So that being around £1.8 million in older people. We've seen the numbers of people in residential care continue to rise, over the past 18-month period. We usually see a natural fall off around winter time. We didn't see that last year, so that impacts on the pressure that we are seeing this year. We're also seeing an increased uptake and value that we're paying out in direct payments. So I could say that's good. We're using this area of the budget to give people more choice in the care that they procure themselves. But we are seeing that increase in spend. Within the learning disabilities sector, we've got a £2.1 million overspend. That is seen within the residential area, so we touched on that with regards to the numbers that we're seeing coming through. We're also seeing an increase in the cost of that care. So people are receiving more one-to-one hours, which is causing the packages to be more expensive than we initially thought when we set the budgets. We're seeing an increase in numbers of daycare and cost relating to that, and that's the same with supported living. So those are a 6% increase in cost of residential care, a 9.6% cost increase in daycare, and a 5.9% cost increase in supported living. Within the physical disabilities area, we're seeing a £1.2 million overspend. Main driver of that is supported living placements. So we've got a 22% increase in the costs that we're currently paying versus the budgeted expectation. We're also seeing a fallout of continuing healthcare funding from the NHS. So we touched on that earlier in Katie's presentation. We're seeing those numbers of CHC clients reduce. So that has a financial impact on our budget. And last area to touch on is mental health. It is demand that's driving this area of the overspend. So we're seeing over a 9% increase this financial year. We haven't seen that level of increase over previous financial years. So I am working with the Mental Health Head of Service to identify, are there any factors that are driving that increase in the numbers of individuals that we need to be aware of, and is it a trend that's going to continue into the new financial year? So the slide on page 68 of your packs shows the numbers of placements that we are seeing starting in April 2020 and an estimate at March 25. Within this financial year, what I can report is that that level of growth is fairly minimal on the overall numbers of placements. So I believe it's a 52 increase in the numbers of packages that we've purchased between March 23 and Q2. So that's, I'm going to say, minimal compared to what we can visually see last year when the growth was over about 200 packages. And then the final slide that I have to present is on page 69, which shows our average cost that we are paying for care. So it's clear to see it is increasing year on year. We would expect that to increase due to kind of national living wage and minimum wage increases that we're seeing, and due to the complexity of the individuals that we're providing care for. So that's the end of my slides. I'm more than happy to take any questions.
Thank you, Richard. Has anyone got any questions? Adrian?
Well, it's just a curiosity, really, because obviously we have increasing costs, but as I understand it, and we're all aware, we have reserves of 105.1 million at the moment at the start of this year, and at the end of 26-27, it'll be 32.3 million. But if devolution actually means we are disbanded, what happens to the 10.2 million usable funds left? Should we be dissolved in 2027?
That's a good question, and one that we are definitely discussing within finance. What I would say is I probably wouldn't be the best person to give you that particular answer that you're asking, but again, more than happy to take it away and report back.
Thank you. I'd hate to leave 10-point-something million pounds in coffers to go somewhere else, but I'm not a finance officer, so thank you very much for that.
Thank you. Richard, is there anything you'd like to add? No? Okay. Thank you very much. Okay, last item on the agenda is our work programme, and this could be a completely different council from May onwards, so we'd like to get it in order, ready for the next panel. We've got... Where's it gone? Can you...
The last page of the agenda, we've got this additional item.
Yes,
Yeah.
so
Do you want me to speak?
can you... Yeah, because I
so-
can't read your writing.
Yes, there was an item that was considered in January which needs to be added on. It was to do with the proposed change in location of the council's residential replacement care provision for adults with learning disabilities, and there was a consultation process, so an update report will be brought back on that, so that needs to go on. And then also you wanted the autism strategy
Yes, please.
added on so we'll add those two matters on.
Okay. Have you got anything else, members, that you'd like to add on, or see if you return and come back, or take off?
No, wait and see what happens.
Positivity, Adrian.
Well, hoping not to. We might be on different committees.
No. Okay, I'll take that then. So we'll leave it as it is, and just the two additions. Okay. Okay, and that just leaves me to thank everybody for their attendance today. Lovely to see you, and hope to see you in May. Thank you. Thank you. Bye.